Welcome, Dr. McCarthy. I am so excited to have you sit down with me today, especially carving time out during ASRM 2025.
Thank you so much for having me, Lisa. I appreciate it.
My pleasure. So without further ado, let's dive into it. What do you think are the highlights of this year's conference so far?
The conference actually just opened this morning, although some of us have been in town for a couple of days already for postgraduate courses. Thus far, I think ASRM is a wonderful opportunity to reconnect with friends and colleagues from around the country and around the world. And what's really wonderful for me about this conference is that you can sit down to lunch with a friend or a colleague, and it invariably turns into a discussion of, what are you doing new? What are you doing differently? Have you seen this study? Have you heard about so-and-so who's getting ready to publish this new study? And so you walk away from every meeting with some golden nugget that you can take home to your patients to hopefully improve their chances of success.
What courses or workshops have you attended?
So I actually did a couple of different workshops this weekend, both of which were postgraduate courses looking at different stimulations that can be used for women with decreased ovarian reserve. And then specifically one looking at women over the age of 40, regardless of what their reserve is. So those were really educational and informational courses for me to take. I really enjoyed them.
Why do you think ASRM is important for multidisciplinary professionals? And what are you hoping to take away to share with your patients back at IVFMD?
I think one of the unique things about ASRM is that it brings everyone together who's part of patient care. So from physicians to nurses to administration to embryologists to psychologists and legal experts, everyone is all in one place. And that's different from almost any other conference. And it allows for a lot of collaboration, which really, I think, in general, leads to better patient care.
So on October 16th, President Trump announced a new initiative to expand fertility access care aimed at just opening this up to everyone in the U.S. What is your message for patients at this time?
Yeah, so this could be a great opportunity for patients, and we're really hopeful, but we don't currently have a timeline for when this might be rolled out and exactly what it'll entail. And so I'm encouraging my patients, certainly the ones who are already pursuing treatment and those who are currently on the verge of taking that step, please don't delay at least getting the consultation, because fertility treatment can be very time sensitive, and we certainly wouldn't want anyone to miss the opportunity to achieve the family building goals that they have.
Absolutely. The plan calls for discounts for EMD Serrano medications. Which medications does EMD Serrano make, and are these medications used in every treatment plan?
So EMD Serrano manufactures 3 commonly used IVF medications. Most of our patients will have heard of these, but Gonal-F, Ovidril, and Cetrotide, and they're all used for different purposes. Now, these medications may or may not be part of an individual patient's treatment plan. For now, the patient's medication protocols are remaining unchanged. The Trump RX plan has not yet announced a launch date, and we don't yet know who will qualify. We're monitoring these updates very closely and making sure that our patients can receive accurate and timely information.
Insurance coverage for IVF and egg freezing still remains a challenge. How could expanding employer fertility benefits help these patients?
Well, if employer fertility benefits are expanded, this could make IVF more accessible for more families. We're waiting for details around the potential new programs. And it is important to understand that time is that valuable resource in your fertility care. So again, I'll encourage not to belabor the point, but I'll encourage patients who are currently experiencing infertility or who are already struggling to build a family, please don't delay in at least seeking that consultation. I think it's also important for patients to know when they're considering making that initial consultation that the first step of fertility treatment is actually doing careful testing, so that we can see if there are easily treatable causes for their infertility. I tell all of my patients that my biggest win is if I can find a simple cause for their fertility issues and I can treat it either medically or surgically or with lifestyle modifications, so that they then get pregnant without needing any fertility treatments at all. I work with patients towards whatever fertility treatment is necessary, if it actually is necessary, but we don't want patients doing fertility treatments if there's another way that we could help them to conceive. When patients come in for their initial fertility consult, a lot of them are worried that they're going to be told right out of the gate that they have to do IVF. And it's really important to know that many patients don't need IVF, and that's something that they'll want to talk with their doctor about. exactly what treatment is right for them in their specific situation.
So important.
Yeah.
So, for those who don't know what ovarian hyperstimulation syndrome is, or OHSS, what causes it and who is at risk?
So OHSS is a rare but serious complication of IVF, and it occurs when the ovaries overrespond to the fertility medications. There are actually 3 stages to OHSS: mild, moderate, and severe. But when people are talking about OHS, especially patients or physicians, we're typically referring to moderate or severe OHSS. Um, Moderate and severe OHSS can be quite dangerous if it's not treated appropriately by someone who's familiar with this syndrome. And so this is where I put in my plug saying ER docs are the bomb. But if you think you have OHSS, call your REI.
Of course. What causes OHSS and who is at risk?
So OHSS is caused by the overstimulation of the ovaries and then the exposure of those overstimulated ovaries, usually to HCG, which is a common trigger medication. The patients most at risk are going to be young women or women with very high ovarian reserve. So think women with polycystic ovarian syndrome.
Can you only get it with IVF or from the other treatments?
Technically speaking, you can get it from any type of ovarian stimulation. However, when you're doing ovulation induction, our goal is to bring up somewhere between 1 and 3 follicles typically. And so you're much less likely to develop OHSS because we're using substantially lower doses of medications. That's why we see it almost exclusively with IVF.
If you do get it, what are the symptoms like?
The symptoms are many of the symptoms of mild OHSS are similar symptoms to moderate to severe. So abdominal bloating occurs in any form of OHSS, but with moderate to severe, you have extreme abdominal bloating, abdominal pain. You can develop shortness of breath. Sometimes that's because the belly is so distended that it's difficult to take a deep breath, but you also can be at an increased risk for blood clots. And so we worry about dangerous things like pulmonary embolus, nausea and vomiting. You can get electrolyte disturbances. You can see decreased urine production, so women aren't peeing as often. And then you can actually get fluid that will accumulate in the abdomen and in severe cases in the lungs and sometimes even in the sac around the heart. Obviously, this is something we take very seriously that needs appropriate management.
So that being said, how do you treat someone with OHSS?
Well, the first and best way to quote unquote treat OHSS is to prevent it. And I know we'll be talking about that a bit later. For women who've already developed symptoms of OHSS, particularly moderate and severe symptoms, they're typically hospitalized, although occasionally moderate OHSS can be managed as an outpatient. Treatment usually involves anticoagulation to prevent those blood clots we talked about, paracentesis or thoracentesis to draw the blood out of, to draw the fluid out of the abdomen or out of the lungs to relieve the pressure and make it easier for a woman to breathe, and IV fluids, because the unexpected part of OHSS is even though you're putting fluid in your belly and you've got so much fluid that you look like the Michelin Man, you're so distended that actually inside your veins and arteries, you're actually very, very volume depleted. So you're very dehydrated. You need a lot of fluid when you have OHSS. Otherwise, things don't work properly. So it's counterintuitive that we would give someone who seems so fluid overloaded more fluids, but that actually helps.
Can it be prevented before it becomes severe?
The best way to prevent ovarian hyperstimulation syndrome is with stimulation management. So that's going to be protocol choices, that's going to be trigger choices, and that's going to be post-retrieval medications and to some degree diet. So protocol, we want to make sure that you're choosing a protocol that would allow you to avoid an HCG trigger and have an effective alternative. Trigger protocols, we usually prefer a Lupron trigger if we're concerned about someone developing ovarian hyperstimulation syndrome, because HCG seems to be the gasoline that causes the fire of OHSS to start. And then post-retrieval, we can use dopamine agonists like cabergoline to help prevent the production of one of the proteins that causes a lot of the symptoms of OHSS, and also some dietary changes, making sure that patients are taking in enough fluid, and it's always a lot more than they think, and also making sure they're taking in enough protein and electrolytes.
What would you want every patient to know about OHSS before they begin their fertility?
Yeah. So, I mean, we've been talking about this. It sounds scary, right? And honestly, it is. And so you need to make sure that you're with a doctor that you trust. So I typically recommend that when you're meeting your RE and you're talking about your IVF stimulation protocol, express those concerns to them. Ask them if they're worried about OHSS for you. Honestly, not every woman is going to be at significant risk of OHSS. And if you are at risk of OHSS, ask them what kind of protocol changes or protocol they are considering for you to help reduce that risk. I also think it's important to make sure that you're actually with an REI. So someone who's done a fellowship in reproductive endocrinology is the ideal situation, because even general OBGYNs rarely see OHSS in training, may not have the expertise that we do from having seen women go through OHSS as part of our training. It's fortunately much less common these days than it used to be. As a fellow, so this is 15, 20 years ago, about 3% of women who went through IVF would be hospitalized with severe OHSS. And the women who had the most severe cases were almost always the women who conceived on their fresh embryo transfer. So things that we have learned over the last 15 to 20 years is freeze all. If there's any concern for OHSS, freeze all the embryos, don't do a transfer. Patients are, of course, always counseled not to have sex during their cycle. And this is one of the reasons why. Because if you get pregnant and you've started down the path of OHSS, your HCG level will rise with the pregnancy, and it will get worse, and it will get worse, and it will get worse. And the sickest women that I've ever taken care of were always pregnant women. And sometimes they can be sick enough that they end up in the ICU. I mean, this is something we take really seriously.
Absolutely.
The other thing that was the game changer was the advent of Lupron or Leuprolide triggers, because it allows us to avoid HCG. Now, keep in mind, you always have to put that qualifier out there. You can still get OHSS with a Lupron trigger, but it is exceptionally rare. So in general, it drops you from about a 3% chance of OHSS to, on average, less than 1% chance. Right now, I think we're estimating that it's about 1 in 1,000 women with a Lupron trigger will end up with OHSS. Obviously, we don't want to push the envelope, but at the same time, if you're taking all the appropriate precautions, it should be something that's relatively rare. So that would be something else to ask your RE about. How many cases of OHSS are they seeing in their practice per year? If it's a high number, and keep in mind, you can't look at the absolute number. If you're at a center that's doing 8,000 cycles a year, they're going to have a higher number than a center that's only doing 1,000 cycles per year. But if you're thinking of it as a percentage, it should be less than 1%. If it's much higher than that, you may want to be concerned and ask them what type of protocol changes they're going to make to keep you safe.
Important stats to keep in mind. I like to ask all my guests these rapid fire questions on fertility trends. Rate them from 1 to 10, starting with highlighting your hair while trying to conceive.
5 out of 10. Number 1, girl, you're already beautiful. You don't need to highlight your hair. But if you want to, go ahead. Honestly, we all know trying to conceive can take a while. And so if it makes you feel beautiful in your own skin, go ahead.
Over-the-counter pain relievers.
8 out of 10. Don't take them if you don't need them, but if you need them, please do feel free to take them. Tylenol, if you've already had that positive pregnancy test, is going to be your safest medication. Try and avoid ibuprofen, Aleve, and aspirin once you're already pregnant.
At-home AMH kit.
I'm going to call those 5 out of 10. I think it can give some patients a sign that maybe they need to see an RE or a little bit of reassurance, particularly if they're early in their trying to conceive journey. Okay, things seem like they're okay. We can afford to wait a couple more months before we make that consultation.
Cycle tracking apps versus a fertility app.
Honestly, I think they're both 7 out of 10. Knowing when your period's going to come and being able to accurately predict when you are ovulating so that you can time intercourse before you ovulate is key.
Do it at home fertility kit.
I'm going to say 1 out of 10. I'm not sure how successful they are. Do at home fertility for me is just doing it at home.
Supplements for egg quality.
2 out of 10. There are a few that may be helpful. Some of the data suggest that CoQ10 in particular may be helpful for women going through IVF. Prenatal vitamins, I don't even consider those a supplement anymore. Those are a must. But the rest of the supplements have varying data. And at this point, I don't typically recommend them to my patients.
Any last words for someone who's listening to this? What's the takeaway?
The takeaway is it can be done. The takeaway is you want to be with the right doctor. If you're going to be doing fertility treatment, you want to be with someone that you trust, someone who listens to you and makes you feel seen and heard. And keep in mind that fertility treatment is one of those things where it can go sideways and it can feel overwhelming and you might feel like your head is underwater at times. But hopefully you're with a team that's going to help you, hold you up and help you float. And my favorite expression is to hold the vision and trust the process. And that's what I encourage all of my patients to do.
Amazing. Now, switching gears, I like to ask all my guests what they like to do for self-care and what you're doing. You're a very busy person professionally, personally, when you're away from work.
My self-care is that my husband and I are season ticket holders for the Florida Panthers.
Amazing.
And so we go to an awful lot of hockey games. Yeah, so go Panthers.
Amazing. And now let our viewers know where they can find you and your social media handles so that perhaps if they'd like to schedule a consultation, they can get in touch.
Absolutely. I'd be happy to see any of your patients. So I'm Jenna McCarthy. I'm based out of IVFMD in Jupiter, and my handle is Jupiter Fertility Doc. And I'm also on the IVFMD Instagram.
Perfect. I'll be sure to include all of this in the show notes. It was such a pleasure to have you today, Dr. McCarthy.
Thank you, Lisa. It was so wonderful to be here.
Thank you.